where to optimally utilize Eribulin varies, I think, really in the subtypes of breast cancer. In triple-negative breast cancer, it's one of the very few agents we have that's been proven at the highest levels, the level 1 evidence, big phase 3 trials, to actually be quite effective in triple-negative breast cancer. Certainly the taxanes are effective. Platinum-based agents are effective. Gemcitabine carboplatin has been looked at in big phase 3 trials. And now we have Eribulin. In the study 301 that compared second-line Eribulin following an anthracycline and taxane with second-line metastatic disease versus capecitabine, they were similar in efficacy, putting all patients together, the triple negatives and the ER-positive patients. There were a few HER2-positive patients in there as well. But when you look at the triple-negative subset, the Eribulin had a 5-month improvement in survival compared to capecitabine, 9.5 versus 14.5 months overall survival. So many of us don't utilize capecitabine as a go-to drug in triple-negative, except for certain circumstances where there's a strong androgen receptor expression, bone only, lymph node only. That's more luminal, and there we do utilize Eribulin. Patients have bone metastasis, even if you don't know the androgen receptor, we tend to utilize the capecitabine. But generally speaking, it's not our go-to drug for the triple negative, with a lot of lung metastasis, a lot of liver metastasis as a single agent. And study 301 showed that Eribulin is really very powerful there. So it's one of our very few level 1 evidence agents for triple negative breast cancer. In the ER-positive group of patients, we do have more options. There we tend to really favor starting with capecitabine. We're trying to minimize the toxicities and to increase the durability of response. The problem with triple-negative disease is that lifespan is so short that unfortunately you've got to get control of that disease, and unfortunately minimizing toxicity is not usually the highest priority. It's called getting on top of this disease and trying to prolong survival. In ER-positive breast cancer, many women will live for years, and so we start off with agents such as capecitabine that have less toxicity, but still very nice opportunity for durable responses. And then we tend to go to a taxane, generally speaking, weekly paclitaxel or nab-paclitaxel, because again of the tolerability, not myelosuppressive, and it can, you usually can, with some dose reductions if needed for neurotoxicity, you can keep going with that agent. You don't have to stop it because of toxicity, generally speaking, before the cancer has become resistant to it. So we tend to utilize those. And then third line, we will often utilize Eribulin. However, Eribulin has more myelosuppression. So sometimes we will certainly use it if we have a heavy burden of liver metastasis. But if patients have more indolent disease, smaller burden of disease, we may hold off on the Eribulin, and we may utilize a single agent gemcitabine, for example. We may utilize that. Some patients will benefit from that. We may utilize single agent vinorelbine, for example, that does not cause alopecia, is a little bit less myelosuppressive than the Eribulin. So we have more flexibility there depending on the natural history and how aggressive that disease is. In HER2-positive breast cancer, there's been a phase 2 trial that I was involved in that has been published that was first-line Eribulin with trastuzumab, looked equally as effective as the taxanes with trastuzumab. Looked every bit as effective. Now, though, what's happened is that the addition of the pertuzumab with the Cleopatra regimen and the FDA approval of taxane plus trastuzumab and pertuzumab, we would not be utilizing the Eribulin first line with trastuzumab. Nonetheless, for patients that need additional proven therapeutic combinations down the line, when they've already had, for example, pertuzumab and TDM1, capecitabine, the Eribulin and trastuzumab combination is a combination that has proven efficacy and safety.
When I think about Eribulin and where it comes up in the flow of sequential use of chemotherapeutics for the treatment of advanced breast cancer, I'm really usually thinking about it after taxanes and after anthracyclines. And nowadays, most patients have had those in the early disease setting anyway, so it's moving up in real time because most patients are already exposed to the anthracycline and taxane classes. So that's pretty much in line with the label indication is when I'm thinking about Eribulin. Oftentimes in the ER-positive space, I'm using capecitabine or venerelbine as the first foray into chemotherapeutics. And thereafter, if patients have already had prior adjuvant therapy, then Eribulin would come up in conversation as one of the preferred options. So it's usually a little bit later line, but I have had remarkable responses and durable responses anecdotally in my practice with this drug, and I've used it since it became available. And it is one of the mainstays in our armamentarium in 2017.
For patients who have had quite a bit of previous neuropathy, for example, from the taxanes, but they've had some good recovery, if you have a choice, you may not want to go back to a taxane, at that time. There are some data actually showing that comparing ixabebolone, for example, to Eribulin, and looking at very careful nerve conduction studies and symptoms, that Eribulin was less toxic, neurotoxic than ixabebolone, for example. And so for patients who have had a lot of taxane neuropathy, the Eribulin has neuropathy as well, but it's different, and sometimes patients will have less neuropathy. And preclinical studies have shown that there's less axonal degeneration in sciatic nerve murine models, less axonal degeneration with the Eribulin compared to the paclitaxel, and a little bit more upregulation of factors that will lead to neuronal growth with the Eribulin versus paclitaxel. Now, I'm not aware, however, of yet very good clinical data with a head-to-head comparison of the paclitaxel to the Eribulin. There has been a study, I think its accrual has been very slow, it may have been closed, comparing paclitaxel to Eribulin. Hopefully we'll get some data. It'd be very interesting to look head-to-head. That's really what you would need to really know for sure. But from a practical standpoint in the clinic, if patients have had a lot of taxane-based neuropathy, have had some recovery, you can give them another agent that does have neurotoxicity. Going with an Eribulin can be less neurotoxic for them. But there is still some neuropathy, and I would expect that I might have to dose reduce, over time, from the standard 1.4 milligrams per meter squared down to the 1.2 milligrams per meter squared, or even down to 1 milligram per meter squared with the Eribulin. Myelosuppression is, particularly neutropenia, largely neutropenia, is an issue with Eribulin. We see that particularly in these more heavily pretreated patients, and you sometimes do end up needing to use hematopoietic growth factors, a dose before the day 8 dose, for example, a dose or two of filgrastim before patients get their next dose of the Eribulin, before the next cycle. And that is something that we commonly do, particularly in the beginning when we're really trying to get the drug delivered, because usually patients really need a response around that time. Over time, you can certainly reduce the dose of Eribulin and try to avoid the use of hematopoietic growth factors, which is certainly reasonable. But a lot of times early on, we're very anxious to get the drug in, keep the patients on schedule, and not be skipping doses, because then you're not going to be able to get a hold of the cancer. We are waiting for results of a clinical trial that we conducted of every 2-weekly Eribulin with utilizing, generally speaking, pegfilgrastim. It was not required, but a lot of patients ended up getting the pegfilgrastim either the day after sub-Q or now the on-body patch of the pegfilgrastim the same day as the Eribulin every 2 weeks. It certainly was tolerable. Now we're awaiting the safety and efficacy data from that. But myelosuppression is an issue with the Eribulin in some patients. Some really do very, very well and don't have any problems at all. But it's not uncommon to want to utilize a dose of filgrastim before the day 8 dose, and again before the next cycle, for a dose or two before the next cycle, to try to keep people on time, particularly early on. And then I think really dose reduction is probably a better way to go, rather than continue to use a lot of hematopoietic growth factors.